We're in Dr. Mark Offer's clinic and he's seeing Dr. Raj Patel. Dr. Patel is the head of history at the local university. His original presentation with myeloma 3 months ago was ISS stage 2, and a skeletal survey showed that he had lytic lesions in the skull, both humeri, and some collapse at L2 and T12. He started CVD treatment and has just completed cycle 3, and it seems to have been responding well so far. Dr. Patel knew that the FISH testing results of his bone marrow were likely to be available between cycle 2 and cycle 3, and phoned up and asked Dr. Offer's secretary for these, and has been told that the FISH shows that he has DEL17P and a gain in 1Q, and he is keen to discuss the implications of this with Dr. Offer in clinic today.
Raj, thanks for coming up today. You've had your 3rd cycle of CVD treatment today. How was things this month?
What do you think? How do I look? Do you think I'm happy with what's happening at the moment? Right? I found out that you're effectively fobbing me off with substandard treatment for someone in my condition. I want to know why.
Okay, you don't seem happy, and I haven't.
Clearly.
Tell me why you think that things are not going.
Because I decided to do my own research. Okay, I joined a group on the internet of international myeloma sufferers. They've been giving me a lot of advice, and effectively, what you're doing is giving me inferior treatment.
Okay, what I'm going to do first of all is just, if I can put that to one side for a moment, I just want to see how you are physically in terms of. I know you were having a lot of back pain before. How's that?
Well, the back pain is better. I mean, it's not as bad as it used to be, right? But that's not my concern. My concern is the fact that, you know, I am basically being prescribed this Velcade, right? And I did some research on the internet, and I had some lots of advice, especially from people in the States, right? They're telling me that there's far better treatments for someone in my condition, right? I've seen my FISH results, yeah? And clearly, that puts me in a very high-risk category, right? I want to know, being such a high risk, in such a high risk category, right, why you're prescribing me a substandard drug?
So, first of all, I'm going to talk a little bit, I'm just going to say that your disease is getting better, okay? And the reason I say that is because your blood tests show that the protein, the myeloma protein, is coming down with the Velcade. Also, your symptoms are getting better. So, this is the context in which we're sitting, okay? That actually the drug is working at the moment, all right? Now, I realise you're an intelligent guy, you want the best for you, I want the best for you, and I said at the start of this, I would always be honest with you, okay? What we've got at the moment is a situation where your myeloma is getting better, okay? Since your last appointment, we've got your genetic results through. We've started to measure, and actually not all hospitals in the UK measure genetics at the moment, but what we've started to realise is that myeloma itself isn't one condition, okay? And that it's many different conditions under an umbrella term.
But from my results, okay, I seem to be an exceptional case, and my condition seems to be worse than most other people's. Is that correct?
That's what these genetic results have shown, is that you have what we call high-risk myeloma, okay? Now, this is, again, I want you to put this in context that your disease is improving. It's getting better at the moment. So it is working, but what we want to do now is we want to do, it's almost like crystal ball gazing. You're a young guy, you're a fit guy. We want you to be as young and fit for as long as possible, okay? The situation is different for you than if you were someone who has been diagnosed in their 70s, okay? I recognize that. Right? And that's why we did the genetic tests, okay? So we can try and work out what's going on. These genetic abnormalities and the high-risk myeloma group, that hasn't been recognized for very long, okay? And if you actually look at the guidelines, and I know you're talking to people everywhere, and it's good to get support.
Because what you're saying is contradictory to what I'm hearing from people like in the States, for example.
And it's good to get advice and support from people elsewhere. But the problem is that we have to put it into the situation of us in the UK, okay? And what I want to do now is I just want to talk a little bit about where high-risk myelomas come from, all right? So probably 3 or 4 years ago, we didn't really know what high-risk myeloma was, okay? We've recognised that if you look back on a group of patients who've been treated, say we have 100 patients who've been treated, and some people have done very well, and some people, their disease has been more difficult to treat. It's come back more quickly. what we're obviously looking to try and do and work out is that group of people whose disease has come back more quickly or has been more resistant to treatment. Why is that? And that's why a lot of work in the last couple of years has gone into the genetics of myeloma. The way that we've realised this is by doing what we call retrospective or look-back studies. Okay, that's very different from actually saying we are able to identify an abnormality and say, right, this is the best treatment for you, this is the best treatment for you. No one's done the studies or the trials yet to say, in your situation, which is the best drug to have, okay? There's lots of speculation, and that's why if you ask 5 different haematologists in the UK what drug to use, you'll get 5 different answers, all right? Now, I realise that getting this information is frightening, it's scary, it's bad enough having myeloma in itself, but actually having someone say you've got high-risk myeloma, it opens up all the wounds and everything from when we were first diagnosed, okay? I realise that, but we will always be honest with you, okay? What we have to do now is to work out a plan of what's best for you, okay? In the context, in the situation of your myeloma that is responding to treatment, okay? What the high-risk myeloma potentially means is that while you respond, we think it will come back sooner. So what we have to do is it's a start of what we're calling is personalised medicine. Okay, so what the treatment for you would be different from the treatment from someone else, which is why it's very difficult when you talk to people in different groups and over the phone, on the internet, to actually compare cases like by like. Okay, so whilst I recognise and it's useful and it will help you with your academic mind to try and work out what's the best for you, I need to do it on what we call an evidence-based basis, and I'm not hugely concerned about other people. I'm interested in you, all right, to do what's best for you. So yeah, we have got these genetics. I haven't had the chance to discuss with them where we go from here. What it doesn't mean is that we change treatment from here because the treatment is working.
But there might be a better treatment. That's what I'm trying to tell you.
Okay, you're right, and the question in that sentence is might, okay?
But surely you should be trying the best treatment for... Look, I've paid national insurance all my working life, okay? You owe me the best treatment available.
I agree. And I have at the moment, while there is speculation as to which drugs are best, and remember, we're in a situation where 10, 15 years ago, we only had 2 drugs to treat you with. We didn't know anything about genetics, okay? In the last few years, we've had Velcade come along. There's other drugs that are starting to come through. And in the last year, 3 new drugs. There's antibodies that you will have heard about. So there's a whole list of drugs that are lining up that will potentially could be really useful. We don't know that at the moment. And what I'm not prepared is to speculate by saying, actually, I will put you on this drug because it's new. I've heard it's good. Let's try that. We need evidence base. And so the way we need to do that and the way that we move forward in haematology in terms of evidence base is looking at clinical trials. Okay. So yes, I want what's best for you, and the way that I think will be best for you, and I'm going to suggest, is we look at clinical trials that are available for you.
Right.
Okay. So what I will do is the nearest centre that might be best for you might be a slight travel, so it might be half an hour, 45 minutes up the road, but if it works for you, I'm going to get you to go and see the people at the centre that's got the clinical trial there to get them to talk through what it would involve. Okay.
Right. Okay, I mean, yeah, and my wife could come along, I suppose.
Of course. So listen, this is realising that you've got high-risk myeloma is difficult. Okay, high-risk myeloma is rare. Right? So one of the big problems in trying to work out how effective a treatment is that usually one of the big myeloma studies we've just done, thousands of people in it. Okay, in the States where they see a lot more myeloma, and you're right to be looking over there. We all look slightly across to see what's coming from the States. But one of the studies to show with high-risk myeloma only had 70 patients in it. It's very difficult to infer what's best for you from a study that's only got 70 patients in, okay? So whilst I will try and use that evidence, I'm not just going to have a knee-jerk rush to say this is what we need to do. We need to do this in a planned manner. We need to do it together, me alongside you. You need to have support, and you need to do it with you and your family doing this, okay? One of the things that we'll be looking to do will be the clinical studies, the clinical trials. If we're not able to consolidate and strengthen the treatment in terms of giving a treatment that we think will get the best response, then one of the things that we can look to do is to talk about transplant procedures. And I mentioned that very briefly at the beginning when I first saw you, okay? That's not something that we would do unless we felt that we needed to do that, because although you're young and you're fit, we think the side effects associated with transplants are higher, okay? So what we will be doing is we'll be evaluating everything that's available to you. If there is a study that we think will be of use to you, we would suggest you going forward to that, and I'm very happy to discuss that with you, as well as you discussing with the people who run the study, okay, along with your family. If we think that doesn't work, then we think we may need to intensify the treatment, and that's by using the transplant.
Okay, what sort of time frame are you talking about then?
Okay, so now we've got the results back, I'm going to start looking already so that we're ahead of the game, essentially, okay? So your treatment is working at the moment. There's nothing to suggest that it will stop working. But what we would need to do is to change your treatment so that you either get more treatment, or you get in terms of a length of time, or you get a more consolidated, stronger treatment, okay? And that will either be in terms of a trial or potentially looking at a transplant procedure. Okay? So they're the sort of things that we need to start helping you get your head around. So I'm sorry you feel that I haven't been honest with you.
Well, I mean, it just seems to be contradictory to what I've been reading up on and the advice I've been getting from people on the internet. That's why I was angry.
No, and if I was in your shoes and I was talking to other people and people are telling you, you need to do this, you need to go in and say you want this, I can understand.
Well, it was first-hand experience of people that are actually going through similar things to me.
I can understand.
So, you know, that's why I believed them.
We are in a situation where we don't know what is best for people with high-risk myeloma at the moment. Okay. Against that, we are in a situation where we can only get certain drugs at the moment, okay, in the UK. And so we need to work through that. And one of the best ways we can do that is to get you attached to a clinical trial. Okay. If I was in your situation, if I was in your shoes, that's what I'd be looking to do. I'd be saying, right, let's see what clinical trials are available. If that doesn't work, then I'll be looking to try and assess further treatment, and that might need treatment in the forms of a transplant, a stem cell transplant. No, of course, and that's something that we wouldn't want to rush into unless we really felt we had to. Okay? Just because the side effects are more than one would expect with your normal chemotherapy treatment. Okay? So what I'm going to suggest is that I will go away and I'll look at I'll contact the trial centres to see which trials are available for you, i.e. someone with high-risk myeloma, and we'll also just touch base with the transplant centre so we get that ball rolling. They can run in parallel, okay? But the take-home message is at the moment, your disease is still responding. What we're trying to do is we do some crystal ball gazing down the line to get that response to last as long as we can, okay? But I'll always be honest with you, and I'm sorry if you felt that hasn't been the case.
Yeah, I'm sorry, I was just very het up when I came in and just, I don't know. I'm sorry.
You've got nothing to apologise about. Why don't we meet up again? I'm very happy to talk to you again next week if you're able to bring your wife up and we can talk through things and we can progress from there. Is that okay? Yeah. Okay.
So that was a really difficult conversation to come into. You were very angry when you sat down. Do you regret phoning up for the FISH results before you came?
No, I prefer to be informed, so I'm glad I was informed. But I might have actually misunderstood exactly, you know, where the treatment was heading.
Yeah, but it did get the conversation off to a pretty sticky start, didn't it?
Yes, I was very...
You had that information
Mm.
because you felt that there'd been a loss of trust
Yes,
with Mark.
yes.
Who? So, without discussing the details of the consultation much more, I'm tempted to just cut to the chase and say, has he done enough to win your trust back?
Ultimately, the way he described my condition in detail, because obviously, you know, the people I've been speaking to on the internet, they don't have an in-depth knowledge of exactly, you know, what my condition is. So I suppose it was more sort of a general.
Difficult, isn't it? Because they're
Yes.
patients, they're people that you identify with, but without the complete expertise that you get across this table.
Exactly, and we are talking about people in a different continent as well. So
But there are people like you with a serious illness
yes,
who are frightened and who want the best, and
much
it's
like me.
difficult not to be swept up with that identification of their situation.
Mm-hmm.
And there's complicated information in there about the reliability of interpreting things in terms of treatment choices.
Yes.
How do you feel Mark did with the job of getting that across?
I thought the fact that he was actually talking to me about options that are available to move forward, I think that kind of set my mind at rest to realise that he was actually looking at you know, helping me rather than just try and tick a box and you know.
I picked up a little bit about the limitations of NHS resources
Yes.
in the middle of that consultation, despite the fact that it looked as though there might be good options in terms of access to trials, transplant and so on to be looking at down the line.
Yeah.
I think there was did you hear that note of warning about not everything's available to everybody?
Yes. Yes, I did. Yeah.
Mm.
But also, you know, the fact is, because I've been looking at a broad spectrum of cases across the world, some standards aren't as high as in this country, and some standards are not as stringent, I don't think, with their testing. So
Yeah,
it's better to be safe, I suppose.
indeed. You think you're in good hands?
I do now, yes.
Lucky to have kept your head on your shoulders the first 30 seconds there.
It was difficult actually. In Raj, I recognised quite early on that I was going to have to do as much as I could to regain Raj's trust, because when he came into this clinic appointment, it was a very different relationship than a month ago after his last cycle of treatment, where I felt that we were progressing well. He was starting to be more comfortable in his diagnosis of myeloma. He was getting better and he was making progress, and then suddenly that relationship, he felt there was a real strain on that. So it's very difficult in the time constraint of a clinic to try and get Raj back on side and repair that relationship, but equally to start to discuss some of the more pertinent issues of what he's brought up regarding the genetics and where to go from here. So that was why I was quite keen when Raj offered that his wife came up, that we try and do that as soon as we can and try and do that next week, because I think today was almost about damage limitation really in terms of our relationship, and I wanted him to go away and have a thought and recognise that we are trying to do the best for him, and there are options. We will have to go forward and explore a little bit more about what we can do in the UK, what trials there are available, and the role of the transplant. But I think just to get him back on side today was what I would.
Leaving aside the details of the clinical negotiation here, I mean, for me, I thought that you spoke about damage limitation there, but I thought the two things that you did that limited the damage and re-established the trust were that you empathised with him explicitly, said, you know, you're in a really difficult situation, and you were unstintingly honest. I think that's what carried you through. Good. Thank you both very much.